best answer to whatever was circulating.
Yeah, thank you. That was the need of the time because the same reporter had initiated the first this thing news in the print media. So I thought that when she started inquiring, then it was the right time to tell her that this is the situation.
Yes, sir.
And
Yes.
sir, you have written in such wonderful way that not, very balancedly you had told in that article, what needs to be done, what are the difficulties. It was a wonderful.
Yes, yes. Thank you.
Because generally in press, what happens is they just start the blame game.
They
Uh,
they don't know. They don't understand the situation. And no,
I think Dr. Rajesh is busy in OT.
So, Sai sir, you should invite that reporter to the webinar.
I just a few minutes before saw the messages Rajesh was putting in every group, and it was flashing that Rajesh is putting some group some message. Then I saw the array, and I was surprised that you are there and Nandini is there. Then I said our meeting was going on. Actually, I am in the boardroom sitting here.
Hmm.
So my MD and all they got dispersed because of this. Because
Sir,
now they are also aware that malignant hyperthermia hot topic going on in Pune city. So I said I'm going to join with this webinar.
but
Take
sir,
all the trustees also
so
with you.
it is nice that you could join because your inputs are really valuable, sir.
Yeah.
Dr. Kelkar madam is there in Mumbai, Pune.
मॅडम असतील
त्यांना फोन करायचा का अनिता मॅडम?
प्लीज करा ना, कारण मॅडम कदाचित व्हॉट्सअप बघत नसतील.
ओके ओके करते मॅडम ना.
Saurabh is there.
Yes, I am.
So I think Rajesh is unable to join, so we will start. Ganesh, when we start, you start recording.
अनिता मॅडम केळकर मॅडमने फोन केला हा ते आपण जॉईन होत आहेत.
Okay, good. Thank you, Shilpa.
वेलकम.
So let us start. I welcome all the dignitaries, respected Dr. Bala Venkat sir, Dr. Pratibha Kane madam, who are chairpersons for today's webinar, and our speakers, Dr. Nandini Dave madam and Dr. Sandeep Mutha, for this SAMS symposium. Today is a very important topic with respect to patient safety, and we are going to discuss about malignant hyperpyrexia. The theme of our webinars is Safe Anesthesia Saves Lives. And so we generally take all the safety related topics in our webinars. So recently we have noted that few cases of malignant hyperpyrexia are happening, and because of the challenges in treating and procuring dantrolene, which is a sole treatment for malignant hyperpyrexia. Let us all come together on a common platform and let us see what we can do about it. So we want to discuss it in details about the diagnosis, signs, symptoms, and the treatment available. So I want to introduce, I'm very privileged to introduce Dr. Balavenkat Subramaniam, who is my mentor, and actually he doesn't need any introduction. He is our ISA national president at present, and he is the World Federation secretary at present. And he was a past president of Asia Oceanic Society of Anesthesia Education Committee member of WFSA, and he is the founder president of AORA and also ASRA PM. So with this very short introduction, because Dr. Balavenkat is doing phenomenal work at all over India and internationally. So it's really not possible to introduce him in 1 to 2 minutes. He is working at Ganga, such a busy hospital, since more than 30 years. And in spite of his busy work schedule, he is at the helm of all the academic affairs at the national and international affairs. So I welcome you, Dr. Balavenkat.
Thank you so much, Dr. Anita.
And Dr. Pratibha Kane, madam. Dr. Kane, madam, is a very well-known anesthesiologist from Pune, and she is, Ganesh, please display Dr. Kane, madam's introductory slide. At present, she is a senior consultant working at Pune and working at Jehangir Hospital, Pune. And she is a very good authority on medical legal aspects in anesthesia. Her areas of interest are neuro anesthesia and pediatric anesthesia. And madam has a long list of achievements. So I welcome you, Dr. Pratibha Kane, madam, for this webinar.
Thank you. Thank you.
Inputs will be invaluable for this.
It's
Now-
good evening, everyone. And it's my privilege to welcome and invite Dr. Sandeep Mutha. He is a director of Pune Anesthesia and Critical Care Private Limited and also director of Mediparva. He is Dean Examination of IACTA ICCA. He is HOD of Anesthesia in Pune Hospital, Pune. He is a past president of IACTA Maharashtra, past treasurer of IACTA. He is a secretary of Society of Regional Anesthesia. He is a past secretary of ISA Pune. He is a ASO president-elect. He has conducted many lectures. We know him for his valuable contribution to anesthesia in Pune, and it's our privilege to welcome you, sir.
Thank you, Vikas.
Good evening, all. I'm Dr. Saurabh Berde. I have a privilege to introduce Dr. Nandini Dave, madam, a well-known figure in pediatric anesthesia. She is senior consultant and head NH SRCC Children's Hospital, Mumbai, ex-professor and HOD, Department of Pediatric Anesthesia, KM Hospital, Mumbai. She is faculty of IPA fellowships and FNB in pediatric anesthesia. She is a AHA certified instructor of ACLS, PALS, and PPLS. She has several publications and book chapters. Joint editor of Principles and Practice of Pediatric Anesthesia book. Associate editor of Pediatric Anesthesia Journal. Recipient of various fellowships and awards like Hargobind Fellowship, JSCAP Fellowship, IIP et al. Fellowships. One more thing, she has a PG diploma in medical legal studies from Symbiosis, Pune. And she has also certification in simulation from Monash University, Australia. Welcome, ma'am.
Thank you so much, Dr. Sir. Thank you. My privilege.
So I request Dr. Sandeep Mutha to start with his presentation.
Let me share my slides first.
Dr. Anita, as he's starting the slide, can I make a couple of introductory remarks?
Yes, sir, sure, definitely. Please do so.
Dr. Sandeep, just a couple of minutes for
No
me.
problem. I'll stop sharing.
This particular topic, it's pretty emotional, very personal to me. In 2018, until the first case struck us, I also believed, like most of the anesthesiologists in this country, that malignant hyperthermia is a disease that is not for India, a disorder that is not for India.
And I kept hearing the statement saying that it is a disorder of the West. But on the February 18th, 2018, though I was not personally involved in that case, it happened in my hospital. This was a 26-year-old young marine engineer who lives in Kerala, who came in to get engaged. He finished his engagement and his marriage date was fixed. And he had 2 months off because he's a marine engineer. So he thought before the wedding, he will correct his shoulder issue. He had recurrent dislocation of the shoulder. So he thought he will get that done. The family was absolutely jubilant mood because the engagement had just happened. And he was posted for a shoulder procedure. And this was the first case which shook us, which gave us sleepless nights. Within seconds of starting sevoflurane, it was done under block and GA. Without few seconds of starting sevoflurane, the end tidal went up, the tachycardia happened. The consultant anesthetist who was looking after the case thought it was a light plane of anesthesia, and he increased sevoflurane and he gave a dose of muscle relaxant. He gave beta blockers. So he altered the tidal volume, increased the minute ventilation. He did all that thinking that it was a light plane and thinking that there was a problem with ventilation. And until he realized within the next 5-6 minutes, the temperature went very, very high and we lost him on the table. On the table. This was the first instance which really shook us. And that day we decided this life can never be brought back. Whether the hospital says I can't store 1 lakh worth material, when we invest crores and crores of rupees in patient safety, in monitoring. But on that day, when we told the administration, we are very happy that immediately they agreed and we bought dantrolene after such a catastrophe. Now, 1 year after that, it had a 2-year shelf life. Maybe 10 months after that, there was a young 9-year-old girl who had come for growth rod application of a spine deformity, again from Kerala. So within seconds of starting the case, the same thing happened, and now the whole department was aware that raise in end-tidal carbon dioxide and tachycardia happening at the same time. The first thing is you need to keep in the differential diagnosis malignant hyperthermia. And the best part is we had the drug. And believe me that after giving 2.5 milligram per kg body weight for that 9-year-old kid, very sweet, smart kid, within minutes, the ETCO2 came back to normal. And that was a big sigh of relief. Since then, we have saved 3 patients going in for malignant hyperthermia. So we've been keeping a stock of dantrolene sodium since 2018. Now, the most important point which all of us have to consider is the new, we are trying our best to get the Natco pharmaceutical in Hyderabad. We visited them in person. So they're willing to manufacture. Raw material is available in this country, but they wanted at least 250 institutions to sign an MOU that they will buy at 1 lakh for that adult dose. If 250 institutions come forward, they're ready to manufacture. Now, that is my biggest challenge. And they wanted this to be signed for 5 years. So that is the biggest challenge now. And that is the bottleneck. Now, meanwhile, we have found out that 120 milligram vial is available. And I put it in the groups everywhere. And I think that looks very cheaper, and 120 milligram is sufficient enough to tide over the initial crisis at a cost of about 1.2 lakhs. Now, if you look at it, it's having a shelf life of 2 years. So 1.2 lakhs divided by 24. So it would be hardly 5,000 rupees per month that is invested on patient safety. Whether you get a case or not, you will save a case if it one happens, because there is no other alternative. Now, our biggest challenge was NATCO did a survey itself after getting the proposal from us, and they chose 40 senior anesthesiologists from 40 different cities in this country, and they gave a telephonic call and asked them, did you face a case of malignant hyperthermia? And all the 40 people said they have not faced one in their life and they will not buy. So this was a huge challenge when NATCO started the conversation by saying, your own fraternity doesn't believe that this can be marketed in this country and you want us to manufacture. So they said, until you sign an MOU and ISA takes, whether anybody buys or not, if 2.5 crores, if ISA can sign, we will start manufacturing. So why I wanted to present all this is, there is a thought block in majority of us. We also keep singing the song that it's a rare disorder. Why waste money? And what happens if we don't use it? It just have to be seen if you undergo a catastrophe. Without taking much time, I just wanted to narrate one more incident and finish my talk. Finish my this introductory. Here was one of the richest transporter in Punjab, in Ludhiana, married 5 years. They didn't have a child. So they went for fertility treatment to US. She became pregnant. They were so jubilant. First 6 months they stayed in US. They were very, very rich. And then the parents and parents-in-law insisted that they come for delivery back to Ludhiana. And I don't want to mention the institution. So she came, it was an elective procedure. Spinal was given, spinal failed. The obstetrician was not willing for a repeat spinal. She said, give GA. GA was given, offending agent went inside. Again, it was sevoflurane that time. Malignant hyperthermia, died on the table. Now, where is this question of us spending 5,000 rupees per month to store a drug? And why should we keep on arguing, saying it will go as a waste? Will we get back all these lives that have been lost in this country because of this? And last, I advertised that I have dantrolene in Ganga Hospital. Since then, I've had so many calls from this country, across the country, saying, please send dantrolene, please send dantrolene. So which means the occurrence is very high. And we need to be cognizant of the fact, and all of us have to commit ourselves to safety by talking to the management in such a way that it's 5,000 rupees per month. And please store, I request, if in this webinar, 100 people are watching this, and we need to consider this is our problem. And I wanted to tell you, there was another famous pediatrician in Bangalore. He got his son operated for a tonsillectomy, 8-year-old son for a tonsillectomy, one of the best ENT clinics in Bangalore. The best ENT surgeon lost the child on the table for malignant hyperthermia. They gave frantic calls. Bangalore is not close to Coimbatore to send dantrolene. He died on the table. How do we answer for all these things that are happening? Do we turn a blind eye to all this and say it will never happen to me? Or take that step forward to make the hospital believe in this? And first, for that, anesthesiologists should believe in themselves, have to quote these instances, and please try your best to store the drug in your own institution. 1.2 lakhs over a period of 2 years is nothing. And now we know there is a source who can buy and give us. Dr. Anita, as the President of State of Maharashtra, It's just not enough to conduct a webinar. It is so important and crucial to change the mindset, need to make people realize, motivate, inspire them, and make it happen. And thanks to Saleh sir, I just heard that his hospital is going to keep a stock in Noble Hospital. So thank you so much for this very, very nice gesture. And I only wish that several of us take this initiative and just quote it 5,000 per month, and it may save a life. Thanks for intruding, but I wanted to share with you the thoughts that have gone into my mind, which made us to store dantrolene right from 2018. Thank you so much for this opportunity. Over to you, Dr. Sandeep Mudda. Thanks for the time, and sorry for taking more time than I actually asked. Thank you.
Hello, Bala. Can I just add one thing?
Yes, madam.
In Pune, we moved a movement asking the Society of Anesthesia members to donate for the dantrolene fund. And I'm very happy to announce that we have collected enough funds and we are in a position to order on behalf of SAP.
Excellent, madam. Thank you so much. Anita, this is a victory for your webinar.
Yes, sir. Actually, in Nashik also we are going to have one dose.
Oh, very nice. Excellent. Thank you. Sorry for the interruption.
Please start, Dr. Sandeep.
Yeah, 1 second. That's the again this sharing I have to stop and do that sharing again. You can see the slides?
Yes, yes.
Yeah. So after a nice introduction by Bala sir, again it is gone.
We can see it.
What's happening? Your slides are not getting scrolled?
Yeah, 1 second. Yeah, it's going forward. After the nice introduction by Bala sir, and thanks to Anita and all the senior people who are there in the webinar, with my senior teachers, my CR, Dr. Anita, who is there, Sai sir, Kani madam, and everybody. So we are going to talk about a disease which we didn't know much, or the problem which we didn't know much in anesthesia, but it is putting its neck up like anything. So we had around 4 to 5 cases in Pune, and all over India there are multiple reported cases which have not been published, but there are multiple reported cases of malignant hypothermia. So I'm starting with a small case, a 20-year-old male with fractured shaft femur for open reduction internal fixation, 86 kg, 40 BMI, ASA grade 1, no allergies, refused spinal anesthesia and opted for GA. Fentanyl, propofol, scoline, sevoflurane, atracurium was given. Intubated, surgery started, the position was given, the surgery started. It went on for around 20-25 minutes. And after 25 minutes, there was a increase in the end tidal CO2 to 49. A tachycardia started occurring. The saturation was still 98%. So as a routine anesthesiologist, we think that the patient is light or the ventilation is not properly being done. The tidal volume is not good. So ventilator were readjusted. They increase the depth of anesthesia, thinking that the patient is in light plane of anesthesia, but EtCO2 kept on increasing to around 70-80. Alarm bell started ringing. So because the anesthesiologist has not seen this type of condition anytime, he asked for a second opinion from the senior. The senior person asked him to check the air entry, check if the patient has hyperthyroidism or he's going into a hyperthyroid crisis, and check the temperature. The air entry was equal, but the temperature was 40 degrees Celsius. So suspicion of malignant hyperthermia was clinically confirmed. Measures were taken to stop the trigger factors and control the temperature, but no dantrolene was available. So temperature increased to 42, ventricular ectopic started occurring, patient had cardiac arrest, CPR was given and revived. ABG showed PO2 of around 90, high PCO2 level of around 110. Lactate had gone to 12, bicarb had increased, or base excess had increased to -10. Patient was stabilized in the OT and shifted to the ICU. In ICU, the body temperature was lowered by cooling measures, which we had done. It had come down to around 38.6, but creatinine and phosphokinase increased to 29,547. The urine output has stopped, so we thought of doing a dialysis for this patient, but before doing that dialysis, patient succumbed and we could not revive him. So malignant hyperthermia is an autosomal dominant inherited disorder characterized by skeletal muscle hypermetabolism when it is exposed to agents like depolarizing muscle relaxants and the halogenated anesthetics. It's basically an uncontrolled release of calcium from the sarcoplasmic reticulum. This also causes depletion of the ATP, increase in the oxygen consumption, increase in the CO2 production, and all this will lead to rhabdomyolysis or breakdown of the muscle cells. Epidemiologically, it is a variable incidence, and as Bala sir has also said that if we ask any of our senior anesthesiologists in India, they will say they have not overcome this type of situation for last 40 years or 50 years of their practice. So incidence is 1 in 5,000 to 1 in 1 lakh in some of the countries. And here we say it is around 1 in 2.5 lakhs. Children are more affected, males more than females. In USA, obstetric population, it is 0.46 per 1 lakh. But if you see this, the mortality decreased from 70% to 5% after dantrolene was introduced in 1970 in these countries where the incidence of malignant hyperthermia was very high. Then why do we say that it is rare in India? It was rare in India because we didn't come across these type of cases, or if these type of cases were there, they were not reported. And sometimes their mild symptoms might have been there. So like some of our senior anesthesiologists will say that, yeah, sometimes with schooling, the jaw doesn't open very fast. So that may be a masseter muscle spasm, which is occurred which is an initial sign of malignant hyperthermia. There is an increased incidence because of the increase in the complex surgeries which we are doing now. Number of surgeries have increased. The complex surgeries has increased. The patients with myopathies, scoliosis correction surgeries, those patients are more prone for malignant hyperthermia. There is scattered incidence all over India, but it was most seen in Kerala state. So we should investigate why in Kerala state this thing was more, malignant hyperthermia was more. So it is pharmacogenetic disorder. Pathogenic variants of RYR1, CACNA1S, and STAC3 genes is there. We'll go to the details of this in the next slides. So it is an inherited disorder triggered by susceptibles in humans and also in animals. So malignant hyperthermia is also seen in animals when they are exposed to inhalation anesthetic agent and succinylcholine. And the underlying physiology is abnormal handling of the calcium channels and the calcium levels. This is okay. Basically, it's a pharmacogenetic disorder. So there is a mutation of 3 types of gene, that is RYR, that is ryanodine receptor type 1, which controls the calcium release channels from the sarcoplasmic reticulum. The CACNA1S, which controls the voltage gated calcium channels, which has an alpha subunit of L type of calcium channel in isomer of sarcolemma. Then STAC3 genes is the mutation of this was normally found in Native American people, where It was known as Native American myopathy. It is basically to do with excitation contraction coupling of the actin myosin fibers. Basic trigger factors for malignant hyperthermia are the potent anesthetics, halothane, isoflurane, sevoflurane, and less amount of desflurane. Ether was also related to it, methoxyflurane, and the depolarizing muscle relaxant. The other agents which we use are not doesn't trigger the malignant hyperthermia. These intravenous agents, opioids, non-depolarizing muscle relaxant, ketamine, propofol, anxiolytics, which we use. So these can be used safely in these patients. So what happens? The RY receptor, that is ryanodine receptor, ryanodine channel will open and close for the calcium. If this opens up and it doesn't close, it will keep on releasing calcium into the cell and cause a contraction of the actin myosin fiber continuously, where there is increase in the conversion of ATP to ADP and increase in the oxygen consumption and release of CO2. So the CO2 will increase, oxygen demand will increase, ATP will be converted to ADP. So the energy stores of the cells will get depleted. This will cause rupture of the muscle cell and leading to rhabdomyolysis. So here you can see that the channel opens up and keeps on releasing calcium through the sarcoplasmic reticulum, and it doesn't close. When we give dantrolene to these patients, the dantrolene will just close this channel and stop the release of calcium. This will dramatically change the scenario, and immediately the entitled CO2 will come down, the calcium release will be stopped, the muscle spasm will also stop. So what is the spectrum of malignant hyperthermia? It can be a fulminant malignant hyperthermia, where in minutes of giving either a depolarizing muscle relaxant or a halogenated inhalation agent, the patient will have muscle rigidity, high fever, increase in the CO2 production, increase in the entitled CO2, tachycardia. All this will happen within minutes or within half an hour or so. The second one is the masseter muscle rigidity, or where which we have seen many times with succinylcholine, but it lasts for a very short time. And there is also a late onset of malignant hyperthermia, which can occur even hours after the anesthesia is over. So masseter muscle rigidity and malignant hyperthermia, it can occur with succinylcholine. We have seen lot of times that the jaw doesn't open immediately after giving succinylcholine. It may have a spasm for around 20 to 25 seconds, but it gets relieved. If it gets relieved, it's okay. But if it lasts for more than 1 minute, there are high chances that this patient may have susceptibility to malignant hyperthermia. So it is more seen in children. It precedes malignant hyperthermia in 20 to 30% of the cases. And when when MMR is there is elevated level of creatine kinase levels, which will also cause myoglobinuria. With the muscle breakdown and creatine kinase level going more than 20,000 international units, there is likelihood of malignant hyperthermia with or without rigidity. So there are multiple muscle disorders also which these patients are susceptible for malignant hyperthermia, like CCD, that is central core disease, or multi-mini core disease, where this is basically a disease of muscles of movement, that is skeletal muscles, and associated with the mutation of RY1 gene. Then Duchenne muscular dystrophy, mainly seen in males, it is progressive fatal muscle wasting. Baker's muscle dystrophy, myotonias, and King-Denborough syndrome, where the patients are short, there is musculoskeletal abnormality and mental retardation. So there is higher risk of malignant hyperthermia in these patients, or malignant hyperthermia-like episodes upon exposure to a triggering agent. So whenever we take history of these patients, and if the patient has some musculoskeletal disorder, we have to be suspicious about malignant hyperthermia that can occur in these patients. So we have to check for that. This is a very short summary. Anesthetics given, skeletal muscle, there is a depolarizing effect. the calcium release is there, which is not stopping. So there is continuous contracture leading to hypermetabolism, heat formation, decrease in the oxygen consumption, increase in the CO2 production, increase in the acid formation, rhabdomyolysis leading to myoglobinuria, renal failure, creatine kinase increase, potassium increase, arrhythmias, tachycardia, and the cerebral damage. We'll go into the details of this. So early signs of malignant hypothermia, as we have seen in the case, we have induced the patient. After around 20-25 minutes, the entitled CO2 starts rising. There is tachycardia. There is increase in the temperature. Then sometimes the urine output can also drop. There is increased oxygen consumption. Then if we send the ABG, there will be a mixed metabolic and respiratory acidosis. If the patient is, if it's a late onset malignant hypothermia where you have extubated the patient, there you can see profuse sweating and mottling of the skin. Cardiovascular effects will be increase in the tachycardia for supplying the oxygen to the periphery. So because oxygen demand increases, there is compensating increase in the heart rate. Cardiac arrhythmias will start occurring because of release of potassium into the circulation and the calcium. There will be unstable atrial pressure. Then muscles will cause a masseter muscle spasm will be there, generalized muscular rigidity and rhabdomyolysis. Later signs is because of the muscle rupture, that is hyperkalemia, rapid increase in the core temperature, elevated creatine phosphokinase levels, myoglobinuria, dark colored urine, cardiac arrhythmias, and DIC. So this is a very complex slide, but this summarizes the whole of malignant hypothermia. We are given a depolarizing muscle relaxant, that is succinylcholine, or volatile anesthetics like sevoflurane, desflurane, and rest of the time, not nitrous oxide. There is an autosomal dominant mutation of the ryanodine receptors, that is RYR1 receptor, and which we have seen that it is on the sarcoplasmic reticulum and controls the release of calcium. The patient has done a vigorous exercise in a heated heat, and his body temperature has increased. So there is lower threshold for activation of the RYR1 receptors, prolonged opening of the receptor leading to increase in the calcium in myocyte cytoplasm, sustained muscle contraction, and a hypermetabolic state. This we call as malignant hypothermia. So when malignant hypothermia occurs, you can have a sustained muscle contraction, which will lead to skeletal muscle rigidity or masseter spasm. The myocytes, when they get depleted from the energy source, that is the ATP, it will cause cell death. When the cell death is there, there is leakage of the muscle content into the circulation and increase in the serum creatine kinase levels. Rhabdomyolysis will cause myoglobinuria and acute kidney injury. Hyperkalemia, because the potassium is coming out into circulation, will cause electrolyte imbalance, abnormal myocyte contraction, arrhythmias, dysarrhythmias, and cardiovascular collapse. The release of thromboplastin will convert prothrombin to thrombin, and there will be imbalance in the thrombotic and the antithrombotic pathways, increased clot formation, and DIC. Malignant hypothermia and the muscle contraction, sustained muscle contraction, can lead to a hypermetabolic state. So in a hypermetabolic state, there is increase in the oxygen consumption, increase in the heart rate to meet the oxygen demand. So to meet this, there will be tachypnea if the patient is awake, that is a late onset malignant hypothermia, or there will be tachycardia, that is the early sign. Increase in the CO2 production will cause an unexplained increase in the entitled CO2, and which we have seen in our case where the CO2 increased rapidly. Increase in the temperature, hypothermia will be there. Decrease in the oxygen supply. Now, once the heart is started failing, there is a decrease in the oxygen supply, anaerobic metabolism, lactic acidosis, metabolic acidosis, cardiovascular collapse, vital organ failures, and coma. So this, in short, is what malignant hypothermia can give rise to. So according to these signs and symptoms, there was a clinical grading scale for malignant hypothermia which was mentioned, which takes into account the respiratory acidosis, where the entitled CO2 goes more than 55 or PaCO2 goes more than 60. The cardiac involvement with a tachycardia, ventricular arrhythmias, metabolic acidosis where the base excess is more than 8, pH is going less than 7.25, and many times we have seen the pH going to 7.1. Muscle rigidity in many of the reports, I have not seen many of the cases of malignant hyperthermia, but what we have seen that had gone to around 6.9 also. Muscle rigidity, there was a generalized rigidity in severe masseter muscle rigidity, muscle breakdown, which we have seen earlier, increase in the temperature, rapid reversal of malignant hyperthermia signs with dantrolene. So if you have a suspicion, you can give dantrolene, and if there is rapid reversal, again it is checked that it was malignant hyperthermia and the family history was there. So according to this clinical grading scale, different scores were given to the different points, which we have seen earlier now, that is muscle rigidity and everything. If the scoring was more than, actually this is 39, not 49. If it is more than 39, then there is a high chances that this patient will have malignant hyperthermia. And if it is more than 50, it is almost certain that this is a patient of malignant, this can be a patient of malignant hyperthermia, and you have to take all the precautions. We think that for the first exposure to succinylcholine or the halogenated compounds, the patient will have malignant hyperthermia. It's not so. So this was a report, delayed presentation of malignant hyperthermia with novel genetic mutation. 46-year-old African American female was there who had undergone a recurrent ameloblastoma of mandible surgery, reconstruction. She had undergone the same surgery, similar surgery 3 times. She has also undergone under general anesthesia hysterectomy and multiple vascular access procedure. But in this 9th procedure, she developed malignant hyperthermia. So it is not that on the first general anesthesia where the same drugs were used. Not in the first exposure to these agents the patient will have. It can be in the 3rd, 4th, or 5th exposure also. Then there is something else. A 12-year-old boy who had a history of malignant hyperthermia once. He was treated well. So he was fine. So now he was playing soccer. And while playing soccer, after playing soccer, it was an intense soccer match which was there. He had fever. After fever, he had rigidity and rhabdomyolysis. And he dies after that. So when he was tested, there was R1 mutation which was detected him and in his relatives also. This was published in JAMA in 2001. So this can happen with a rigorous exercise where actually the body temperature increases and muscle is used up so much that muscle heats up. So what happens? There is a leakage of calcium through the receptors coupled with production of the reactive nitrogen species which bind to the ryanodine receptors. This will increase the porosity and the calcium will get released from the muscle more. And this will be basically seen when the muscle is heated up. When the muscle is heated up, that means either the patient has a heat stroke, that he's gone into heat for a longer time, or he has used the muscles for a very long time and the muscle have heated up and there is a leak of calcium. So when we see a patient of where the temperature increase, we should be suspicious of malignant hyperthermia. But there are some differential diagnoses like heat stroke, hyperthyroidism, because in this patient also we checked for hyperthyroidism is there or not, or hyperthyroid crisis is the patient is going or not. Multi-organ dysfunction, osteogenesis imperfecta, pheochromocytoma, and rhabdomyolysis because of even the pressure on the muscle for a long time. Other differential diagnoses are like environmental heat gain, drug toxicity, exercise hypothermia, some of the syndromes, hypokalemic periodic paralysis, which was seen in some of the syndromes. That is one of the syndromes which we had mentioned earlier. Then in the Duchenne's and the Becker syndrome. So in the Duchenne's and the Becker syndrome, you can get hypokalemic periodic paralysis. So what we should be doing in our pre-anesthetic checkup, we should be asking some of the specific questions to these patients now, and we should add it in our PSC screening, like a personal and the family history of any anesthesia complication in the first relatives, in the siblings or any of the closer relatives. Then any muscle disorders which were there. Any unexplained fever, very high grade fever, where it was not explained after the surgery or was over or after the patient has exercised. Was there a history of masseter spasm because of any reason? Not by anesthesia also, not by the drugs, but any reason if there was a masseter spasm. Then if these are malignant hyperthermia susceptible patients like myopathy is there or not, muscular dystrophy is there or not, scoliosis, if the patient has a history of heat stroke, musculoskeletal disorders, we can also ask for if the patient had any time when he had gone into the heat, had a cola colored urine. This is basically myoglobinuria. If the patient has a history of cola colored urine, you should be suspicious that there is a chance of malignant hyperthermia in these patients. Then we can do a genetic testing, and the gold standard testing is the caffeine halogen contracture test. So what is caffeine halogen contracture test? Where it is a gold standard, but it is available in only 30 centers worldwide, 3 centers in US, 2 centers in Canada. In India, mostly, in my opinion, one center is there in Nizam, that is Hyderabad, and not many places they do this test. So it requires around 2 grams of skeletal muscle from the thigh, and it is exposed to caffeine, halothane, or sevoflurane. These ryanodate receptors are exposed to that, and they see for the muscle contractile properties. But this test has to be done within 2 hours of taking the biopsy. So it's better to take them to the muscle biopsy center and do it. So if any suspicious patient is there who can go into malignant hyperthermia, you want to check it for that, you have to take it to this muscle biopsy centers. The sensitivity is close to 100%. There are false negatives are rare, but specificity is 80%, 20% can be false positive. The next testing which we can do is the genetic testing, where isolation of DNA can be done, but there are 200 mutations of RY-R1 genes, out of which 30 mutations are associated with malignant hyperthermia. In all the patients, 50 to 60% had RY-R1 mutation, and in 1% they had CACNUS1S mutation. So when they do RY-R1 or DNA variant gene characteristics which are seen, unrelated polymorphism, causative mutation, which is very important, and indeterminate. Causative mutation is a diagnostic of malignant hyperthermia. So once the causative mutation is found in any of the patients, the family members have to be tested for the genetic test for the same causative mutation. And if they are found to be positive, they will be labeled as malignant hyperthermia susceptible patients. And they may not go for the muscle biopsy contracture test. So as we had seen, the muscle biopsy contracture test in USA costs around $5,000. Then whole gene sequencing can be done. I had discussed with Dr. Kaumudi Godbole, who is a genetic specialist in Pune. So she said that single gene sequencing is mostly not done because there are multiple genes which are which can give rise to malignant hyperthermia or skeletal muscle disorders. So exome sequencing of multiple genetic disorders is done. Where 5 ml of blood is required in EDTA bulb and sent for biosequencing in labs in Delhi and Bangalore. So multiple labs are there in most of the cities which collect the sample and send it. It detects all the genetic disorders. So one of the labs had written the complete genetic checkup was costing 1,30,000 rupees. And some of the labs were the specific for malignant hyperthermia, which was there, it was costing around 15 to 30,000 rupees. And one of the labs, that is DNA lab in Hyderabad, the RY-R1 gene study was 20,000 rupees, and it takes around 3 to 4 weeks for the reports to come. So if the family has a history, it should be done for these families. So prevention of malignant hyperthermia complications. So we have to avoid the trigger agents. Then take a proper PAC, that is pre-anesthetic checkup. The family history has to be checked, that is neuromuscular disorders and susceptibility to malignant hyperthermia. test the family members. If you get any of the family members who had malignant hyperthermia or came positive for the genetic testing, then during our monitoring, temperature and end-tidal CO2 both should be monitored in all the general anesthesia patients. In my opinion, very few of us will be monitoring temperature. End-tidal CO2, most of the institutes will be having and they will be monitoring. But in nursing homes, they don't have end-tidal CO2 also. So any general anesthesia case, end-tidal CO2 and temperature has to be monitored. If we have given scoline and there is a tight jaw, that is masseter muscle rigidity is there, you should think of malignant hyperthermia. Prompt investigation when there is unexplained tachycardia, hypercarbia, and hypothermia. And make dantrolene available. And I request, like I told Dr. Bala also, that we should tell the regulatory authorities like NABH to make it compulsory for any bigger hospital, that is, if I say 100-bedded or 150-bedded hospital, to store dantrolene with them, as compulsorily store dantrolene with them, then it will be better, and then there will be less resistance to bringing dantrolene because NABH is well sought for. OR should perform regular malignant hyperthermia drills in these patients. Now, where can we get it? So there is a contact number from Trivandrum. This is all from the WhatsApp messages which we got when we tried to search for the dantrolene. So from Trivandrum, one contact number was there. Then from Prabhadevi, Mumbai. Then Indian Pharma Network, they have a large network all over India and they can supply with both the types of, that is 20 milligram dantrium also and 120 milligram also. There are phone number, but there are regulatory authorities which are there, some regulations, some licensing you have to take for procuring dantrolene. So it's not very easy or straightforward in getting dantrolene also, but once you do it, then you can store dantrolene with you and it will be a good thing for everybody. So these are the suggested papers. Larch had done a lot of studies into it and then formed the scoring scale. Thank you. Thank you, Anita, for giving me opportunity to talk on this topic. I hope so. It was in time.
Yes, yes.
I didn't
Thank you,
check because
Dr.
yesterday I checked my time. It was around 22.5 minutes, 22
Okay.
minutes and 50 seconds.
Yes, so thank you for giving the basic diagnosis, signs, symptoms of malignant hyperpyrexia. And I think Dr. Bala sir has left because he had a VIP patient. So we will have Dr. Kane madam's chairperson's comments on this, and then we'll go to next lecture. And then we'll take the questions at the end of both the lectures. Kane madam, please unmute.
Okay, Dr. Mutha, I just wanted to ask you, suppose now we've got a little bit more knowledge than what we had a year ago. But so when the temperature goes up, EtCO2 is going up, what are the 5 things that you would like to tell, that the anesthetist should immediately do? You said send investigations and all, but what about in the theater? Is there anything that you would like to?
Madam, I can tell you all the things which can be done here, but that way encroach on Nandini Dave's lecture.
Okay, so we'll wait for that,
Yes,
and then I thought we'll take the, that's what I thought, that we will, let's see what she has to say.
Madam is going to tell about the treatment and everything. So,
all right, okay.
Okay, thank you. Am I audible?
Yes,
ma'am.
And my screen is visible.
Yes.
Thank you. So thank you to SAMS and ISA for this opportunity. It's really a privilege to share my experience. I bring greetings from SRCC Children's Hospital. And Anita asked me to title my talk as Malignant Hyperthermia, Lessons Learned. But as I'm going through, experiences which have been shared by Dr. Bala and the others also, I really wonder whether we have really learned many lessons, because we like to think that it doesn't occur here, it doesn't happen to us. So this is what I'm going to do over the course of next 20-25 minutes. is share some data from India, discuss a clinical scenario which I encountered very recently, talk about certain diagnostic dilemmas, the treatment of MH, which is the focus of my talk, and then after an episode, what after investigations and testing, and share a bit about my personal journey and what we can do going forward. I must say that it might be a bit of overlap with Dr. Muta's talk, and those parts I will skip or go through quickly. But I think it is worth reiterating certain things because I think we have an audience which is extremely interested, and I can see in the chat there are so many questions and so many suggestions from all of you. So thank you to the audience for joining in such large numbers. So this is actually my tryst with MH, if you can say, started in 2008. When we had a case, a 4-year-old boy who was undergoing a hernia surgery, and we gave him sevoflurane, LMA, brief procedure. At the end of the surgery, we noticed that the temperature was rising, the CO2 was rising. We sent a CPK. We of course didn't have dantrolene. We sent a CPK, and that came in the thousands. We started cooling measures, and luckily he survived. So we wrote a letter to the editor. Dr. Iyer was my professor at that point of time. I was a lecturer. And if you can't see this slide, it's because nobody can see this letter. So if you Google the citation, it doesn't appear. And when I found out from the current editor, it's because IJA was not indexed at that point of time. And that is why I cannot find this letter. So I did some more data searching, and this is what is there, available on the net. So there are some 5 cases which have been reported until 2019. And this is Ramanujam's article, which was the 6th reported case report. All are case reports. And if you look at, second, I try to see my own screen. Yeah. Just a minute. I'm just trying to minimize this so I can see my own screen. Sorry for that. Is my screen still visible? Sorry. Anita?
Yes, it is visible.
Okay. Just a minute. I just minimized that and I can't see my own screen. Just sorry for that.
Maybe you can start from the beginning and then take your
Stop
slides
sharing
further.
and start sharing again because I can't see my big screen. That's the only
Yeah,
problem.
you can stop and again restart sharing maybe.
Let me try. Okay. So this is okay now? All right. So this was the article in 2019, which talked about past 1, 2, 3, 4, 5 cases which were reported. The common element in all these case reports is that there was an exposure to inhalational agent. In some cases, choline was used. Only in one case, somehow they managed dantrolene, and almost all the patients survived. Actually, all patients survived. So probably that is why we thought, even if it happens to us, it's a mild case and we will get away with it. This is somehow the complete list. So actually the first reported case in India was 2001. This was in AIIMS, and this patient succumbed. Exposure to isoflurane was there. Then this is my case report. And following that, Ramanujam's article in 2019, and very recently this article from Pune, where this 19-year-old child, scoliosis. And the hallmark in this case is that they managed to do the gene testing. And that patient, although the patient succumbed, they got the gene testing and she tested positive for the RYR gene. So yes, MH seems to occur in India. There are sporadic case reports, and these are only the reports which are reported. So ever since we got dantrolene, I know there are so many inquiries, and I'm almost certain, like Dr. Bala said, there are more cases which are happening. We don't report it for several reasons. Maybe medico-legal, maybe we are not reporting anyway otherwise also. So those may be the reasons. Now, coming to my recent case, what happened was there was this 13-year-old child who was undergoing scoliosis correction for neuromuscular scoliosis in another hospital. And he had the only positive sort of findings, maybe developmental delay. He had a seizure disorder. He was on valproate, but there was no previous surgical history. The investigations were all okay, including the echo. Now here, general anesthesia, endotracheal intubation, they had given scoline and propofol, and the patient was being maintained on sevoflurane. So a few minutes actually, when they turned prone, patients started developing tachycardia, hypotension, hypercarbia, hyperthermia, the typical, kind of story. Arrhythmias, this patient developed ventricular tachycardia. They managed that. They managed with cardioversion, amiodarone, vasopressors, and then he was shifted to our hospital for further management. They stopped the surgery, closed the incision quickly after making the patient prone, and they somewhat stabilized the patient and got the patient to our ICU. Now, in our ICU, they again continued the stabilization. The patient was already intubated, so they continued the hyperventilation, started 2 vasopressors, amiodarone was continued, hyperkalemia was managed, fluids was started to ensure diuresis. And it was only a few hours later that they thought of consulting anesthesia, because ICU was also not thinking of malignant hyperthermia. So then they called us, and then looking at the whole sort of scenario, and scoline was used, sevoflurane was used, and the entire picture, we felt, yes, it could be malignant hyperthermia based purely on clinical signs. And then we administered dantrolene, and aggressive cooling measures were instituted. So this was our stock of dantrolene. We had dantrium pack of 20 milligram per vial. So this patient was about 20 kg. We needed 3 vials immediately, and then 3 vials were continued as an intermittent doses later on over the next 24 hours. So this was how the patient did in the hospital after dantrolene, and this was my first experience of actually administering the dantrolene. Nobody really knew how to, see the effect. And it was dramatic. It was like magic. Gave the dantrolene, within about 15 minutes, the tachycardia started settling, and the BP actually started shooting up because he was on 2 vasopressors. And then we said, okay, we stopped the adrenaline and the NORAD, and then the fever started coming down. Also, the cooling measures were also on, but it took a matter of about 15 to 30 minutes for the dramatic effect of dantrolene. And then we continued the dantrolene. I'll come to the dose of dantrolene and how we should do. He was extubated the next day. And then there was this lingering surgery which had to be completed. And this surgery is completed 1 week later after we were sure the patient is out of the woods, using trigger-free anesthesia. And then he was discharged home. So the problem with MH, and as Dr. Sandeep has also elaborated so well, is that we tend to get confused with the signs. So the problem is that if there is tachycardia, there is a rise in ETCO2, we think, okay, tachycardia patient is light, we'll give more anesthetic, which is usually sevoflurane in our case. If there is a rise in ETCO2, we will check the tube, we will check the soda lime, we will hyperventilate, but we will not think MH. If there is desaturation, again, we are going to think of common measures. And I'm not thinking that is wrong. I'm not saying that it is wrong to think of common things first. But if you're getting hyperthermia, if you do the labs that time, you're seeing acidosis, you're seeing hyperkalemia, you must start thinking MH. Unless we think about it, we are not going to be taking the appropriate measures. Another finding which has been described in the articles which have been reported is the negative EtCO2 to arterial CO2 gradient, which means normally the PCO2 has to be higher than the EtCO2. But here you might get a negative gradient, and that is explained on the basis of a higher cardiac output and a very high CO2 production. So you might get what you see is a reversal of the EtCO2 to arterial CO2 gradient. So moment you're looking, that means you're investigating, you're actually sending an ABG, you're looking at all the signs. That is when you will think maybe it is something more to do than just, a tube-related issue or an issue with the soda lime or some other common issues which we normally rule out. So this is a differential diagnosis, and I'm not going to go into it in detail because it has been discussed amply. So, we think about insufficient ventilation, we think about inadequate anesthesia, analgesia. It could be surgery related. We think it is, laparoscopy, they are insufflating CO2s. That is why the CO2 is going up. Maybe it is related to tourniquet ischemia. After release of tourniquet, you might find something. It could be anything related to the patient, or maybe anaphylaxis or neuroleptic malignant syndrome, which is more common than MH for sure. So now, once we have decided or once we have thought it is MH, what do you do? That is the focus of my talk. So first of all, you immediately discontinue all the trigger agents. So if you started sevoflurane, isoflurane, or any of the halogenated anesthetics, you stop that immediately. If you're worried about it is inadequate anesthesia, you start propofol, start dexmet, do some other agent, but at least stop what you think can be the offending agent here. Hyperventilation with 100% oxygen because you want to wash out that CO2, you want to correct the desaturation at high flows. Now, why high flows? Because you want to wash out all the sevoflurane or the isoflurane which is there in the circuit and in the machine. If you have not intubated already, you must intubate because that is the only way you can hyperventilate the patient safely. Call for help because this patient could deteriorate anytime. Notify the surgeon, ask him to complete the procedure ASAP. And administer dantrolene because dantrolene is the only antidote. The rest are all supportive measures. So administer dantrolene, which is why we are talking about having dantrolene, stocking dantrolene, procuring dantrolene. And I'll come to the doses in the next few slides. Obtain a blood gas. So you don't know what is happening. You're seeing hyperthermia, but you want to know what else is going on. So this is how you will know if there is a degree of, if there is acidosis, if the base excess is more than -8, administer soda bica. And then cooling, of course, by all routes. Here a point of, we talked about, Dr. Sandeep said many of us are not monitoring temperature. See, unless we monitor temperature, how are we going to know that there is hypothermia? You're going to be treating only hypercarbia, which you think is because of hypoventilation. So a word to monitor temperature in all cases, at least skin temperature, you must monitor. Even if the case is about 15 minutes only, put the temperature probe. It is non-invasive and it will give you data. Most of us are not really touching the patient nowadays. I remember in our residency, we would always have a hand-on pulse. Some part of the patient will be exposed and you will be touching the patient continuously or at least intermittently. Nowadays, the patient is under drapes far from us. For surgeries where laparoscopy, robotics, we are not even touching the patient throughout the surgery, which may be hours and hours. So monitoring the patient definitely for skin temperature, and it is recommended for any case which goes on more than 30 minutes, you must monitor core temperature also, because skin temperature can also be fallacious. What if the temperature probe has just come off? You will not know the temperature and you will just be monitoring room temperature. Now, if you have charcoal filters, and again, this we found out when we had, when we was talking about dantrolene, these are not available in the country. Maybe it is another thing which can be made available by talking to the companies. So this is recommended for preparing a patient for known MH susceptibility, but also it can be used during treatment because you want to quickly remove all the inhalational agent which is there in the circulation in your soda lime in your circuit. So if you attach it, it is said that within minutes that can be absorbed by the charcoal filter. So this is something which can be considered. Moving on to the treatment, treating hyperkalemia, treating dysrhythmias. Here, amiodarone is the drug of choice. Avoid calcium channel blockers. Diurese the patient to ensure that the kidneys don't shut down. If you have sent the labs and you're seeing potassium rising, you're seeing the CK rising, you assume myoglobinuria, and you administer soda bicarb as an infusion in addition to the bolus you may have given at 1 milliequivalent per kg per hour. You monitor core temperature if you have not already started monitoring. Monitor urine output, that means put in a catheter. If you don't have arterial and central venous lines, this is the time to put in those lines. Follow the heart rate, core temperature, carbon dioxide, blood gases, potassium, creatinine kinase, urine myoglobin, and coagulation studies. Moving on, hyperkalemia management. This is just so that if anybody wants to take a screenshot, either calcium chloride or calcium gluconate, soda bicarb, glucose insulin for management of hyperkalemia. And if there is refractory hyperkalemia, I saw a question in the chat. Of course, you can dialyze, you can put the patient on ECMO. All these measures can be done. So in a nutshell, the treatment summary, stop the anesthesia triggers immediately. This is of core importance because I believe that more the, what can I say, the offending agent is given, worse would be the outcome because the patient has been exposed to that much quantum of your trigger. So moment you're thinking there is something off, it is best to stop the triggers immediately. Hyperventilate with 100% oxygen. Dantrolene, the only antidote. The rest are all supportive, I repeat. Hyperthermia cooling measures, which means core cooling by giving IV cold saline at 4 degrees. They have also talked about NG tube and cooling through the Riles tube, although I've read some reports that can cause stomach rupture or even bladder rupture if you're thinking about bladder cooling. So maybe IV cooling and also ice packs by surface cooling, monitoring and sampling, hyperkalemia management, acidosis management, arrhythmia management, preventing AKI by diuresing the patient, looking for a DIC and then again DIC management, and then monitoring the patient because there have been reports where even if you're treated acutely, there can be a recrudescence or a resurfacing of the same sort of picture after a few hours. dantrolene, the drug for treatment of malignant hypothermia. The starting dose is 2.5 milligram per kg. And what we have are 20 milligram vials. So that needs to be dissolved by vigorous mixing with with water for injection. That is 60 ml. So you need to actually take that 50 cc syringe, put in that, and it takes a bit of time. So you need to put at least 1% that responsibility for continuously preparing the drug. If your patient is an adult patient, you can imagine the number of vials you're going to use. If you have the 120 milligram preparation or the 250 milligram preparation, it probably will be easier, but I think it is maybe not that cost effective. So if you are, say, going to have a variety of patients, right, from a child to an adult you are treating, then maybe the 20 milligram vial may be more economical is what I would think. In our case, we felt 20 milligram is okay because we are purely a pediatric setup. Again, further doses of 1 milligram per kg to be given every 5 to 10 minutes until the metabolic signs resolve. That means the tachycardia is coming down, the temperature is coming down, the hypercapnia is under control. And again, beware that the recrudescence of the hypermetabolic reaction can occur, they say, up to 14 hours after the initial resolution. So you need to continue to give the dantrolene every 6 hours. That is what we had done. There is no upper maximum limit for dantrolene. Although it is said that if you're given up to 10 milligram per kg, the bolus dose, and still nothing is happening, then means maybe you have to think of some other differential and it is not malignant hyperthermia. So there are different formulations which are available. One is the Dantrim, which is 20 milligram per vial, and the other one is the 250 milligram per vial. And in this webinar, I also heard about the 120 milligram per vial. This table is from Smith, so maybe the 120 milligram is a new addition. It is reconstituted in mannitol. Actually, it is made in mannitol. It has got that in the. So you see that in our patient, we found that we had not even given the Lasix. But after giving the Dantrium, the urine output started like anything. And then we figured out it is because of the mannitol in the preparation. So that is probably a good thing. And the shelf life varies from 1 year to about 2.5 years to 2.5 years. So you have to see how long your vials are going to last. Now, how will you know that the patient is stabilizing? The PCO2 is declining. It is coming back to normal. The heart rate is stabilizing. The dysrhythmias are disappearing. The hyperthermia is resolving, and the muscle rigidity, if it was there, that is also resolving. So this is in a nutshell. This is from the MHAUS helpline, and you don't have to, it is from the website. MHAUS stands for Malignant Hyperthermia Association of the United States. So we don't really have to remember all the doses or what we have to do, and it is actually virtually impossible to remember all this in a very rare case. So we also have our, we have what is known as a pedicrisis checklist, and I'll give you that, link also in my last slide. Basically, whatever, sort of emergencies are occurring, we have a sort of a laminate, which is there in a binder, and we just have to open that page and we see, and we did that for the MH also, because when they called me to the ICU, and I really couldn't remember all the doses of dantrolene. So we actually got that checklist out and we read it out, and this is how we administered. So you need not really read this whole slide, but it is available. You just have to type MHAUS and you will get the whole checklist online. Can we prevent MH? This is a big question. So one thing is, of course, Dr. Sandeep has also emphasized very nicely that preoperative assessment and identification. So you asked that question. We usually ask, has any of your family members had any adverse anesthetic event? And if at all, they will tell. So if at all there is any suspected history, you treat the patient as MH susceptible. So you avoid all the triggers. You don't want to play with fire. You avoid succinylcholine in any muscle disorder. Now, most pediatric anesthetists have stopped using succinylcholine for various reasons. And one reason, big reason, can also be MH. So if you have any patient, has a myopathy, has hypotonia.
I dropped him at Kabir's house.
Okay. So you can avoid scoline, and you be very, very cautious with inhalational agent. Now, if somebody is very cautious, they may even avoid the inhalational agent, and you can go with TIVA. But I have not put it as a mandatory thing in my slide, only because how many of us have got, access to TIVA? And also when you're using TIVA, then ideally you should also be using BIS, because then you're dealing with the risk of awareness. So I think it is time we should have alternatives. We should have availability of TIVA, TCI pumps ideally, and also BIS monitoring if you're going to have a suitable alternative to a patient where you cannot use any of your inhalationals. Core temperature monitoring in patients with more than a brief anesthetic. By brief anesthetic, they are talking about more than 30 minutes. So if you have a patient who's going to be, undergoing GA for a longer time, maybe it is useful to put in even a core temperature. It's really not very invasive, I would think. An MH card for ideally, yes. If you don't have dantrolene, try to procure dantrolene. But if it is there at some other center also, which is nearby, it's okay. But at least keep the cold saline. Because in an emergency, even cooling that saline is not very easy. So we are lucky because we have a very strong cardiac, team. So they have the cold saline for their needs. So it is always there in a fridge. But at least this is one of the simplest things you can do is have the cold saline at least ready. Other things you will, of course, do. Hyperventilation is there and, labs and other things all you will have. But at least I think as a simplest measure, if you have to do something today in your change in your practices to have cold saline. And of course, then family counseling and genetic referral, which I'll come to later. Now, after the event, what to do? Dr. Mutta has touched upon it, but I will also reiterate this. Now, there are two ways to do to find out MH susceptibility testing. One is the genetic testing, and one is the muscle contracture biopsy test. I talked to my geneticist, who is attached to a hospital, and she said there are actually several labs in the country which are available who do these genetic tests. But the problem is how accredited they are, how reliable are their tests. So she says rather than your association linking with a lab, it is better they actually link with an association with a genetic, and we have the Indian Association of Clinical Genetics is also there. So maybe as an association, we can tie up with our genetics colleagues and see which labs are accredited, because otherwise it will be like any histopathology test. If you are doing the testing and again it is not very reliable, then what are you going to do? So it is a simple test. It is non-invasive. It uses the individual's DNA, so blood or buccal smear, and the positive result confirms MH susceptibility. So you have RYR positive or a CACNA positive, you know that the patient is going to be susceptible, and then you test the relatives also. But the problem is the negative result does not rule out MH susceptibility. So that is a catch here. Then the next thing is the biopsy, the contracture biopsy test. Here you need an open incision. Usually from the quadriceps, you will take a muscle biopsy. Again, to my knowledge, there is no center in the country which does this. Dr. Mutta talked about the lab in Nizam. I do not know about this. The disadvantage is that it is invasive and there are limited centers. He talked about 30 centers across the world, and it's true there are very few centers. And you have to perform it also very quickly. So how within 5 hours of the excision you're going to send it, and I do not know. The good thing is that if this is positive, 100% the patient is susceptible. So then you can test the relatives also. So now who should undergo testing? The patient or the family with clinically suspected MH after exposure to the triggering agent, or if there is any other history of exposure of rhabdomyolysis. So patient gives history of cola-colored urine after intense exercise or a heat stroke, then again it is useful to test these patients. So this is in a nutshell. Suppose you have a MH suspicious event, then the simplest thing is to go for genetic screening because it doesn't cost that much. A rapid test is available, I'm told, in about 2 weeks, and it costs only about 14,000. And then the more comprehensive test, which will take about 4 weeks, it costs anywhere between 60,000 to a lakh or so. If that is positive, you're sure that the patient has got a susceptibility. If that is negative, then ideally you should go for a more invasive testing to rule out or test positively. Comprehensively, you should know whether it is positive or negative. So that is what is recommended by our genetics associations. Now, my story. Now, when I joined SRCC, I realized that this is our patient profile. You have syndromic patients, you have patients. I have had patients who have come to me with a proven RYR mutation. And the parents, I've had to say that, this patient, we have susceptibility to MH, but unfortunately, we don't have dantrolene. But I still think that when the patient comes with a positive genetics test, it is good for us because we can avoid the triggers. But we have most of our patients who will have no screening done, and they will just come and they will have some myopathy, they will have delayed milestones. And in children, we know that the incidence is double that in adults, or even triple that in adults. And sometimes they are so early that you think it is just delayed milestones, and we don't know whether it is hypotonia, whether it is a myopathy. And these are the patients you have to really look out, be very, very careful, because you give a triggering agent, then they could have a full-blown MH. So that is what led to my crusade, if I may say so. And I've been trying to get dantrolene for years. I mean, almost 6 years now. I'm in my hospital, and we got dantrolene about 2 years back. So what turned the tide for us? We had a presentation. This is Vinisha, our past fellow. We had a presentation in our hospital, and we talked about how we have all these patients who are susceptible. We have these patients who are genetically proven susceptible, and we still don't have dantrolene. So that is when our hospital also started thinking that, okay, we need to have something, and we need to get the dantrolene available. Again, cost was a big sort of stumbling block for us. So that is a problem with MH in India. There is underreporting for sure. We all know that. There is a lack of a national registry. So even when I had to find out which cases have occurred, I had to literally search through the net, and some are in some non-index journals, some are in some international journals, some are in some journal of ICU, critical care rather, not in anesthesia. So it was a big, effort for me to find out how many have been reported. There is lack of genetic testing. So even if you have I don't know why some lines are happening in my screen. Anyway, so lack of genetic testing. There is not, even if there is, you think it is MH, you don't have a diagnostic test. And there are economic constraints. So if you want to test the patient, again, patient will not have money. If you want to stock dantrolene, hospital will not have money. But I think the biggest problem is the lack of awareness amongst our own colleagues, ourselves, that MH can exist, MH can happen to us. And we think of everything, we don't think MH. Till recently, till last month, till this case happened also, our ICU colleagues are not thinking that it could be MH. Our own anesthesia colleagues are not thinking MH. And nobody had thought of even asking for dantrolene until we were called in. And we only thought we could give because we had it. Otherwise, we would also have treated symptomatically. That is a problem. So how did we go about it? And I would really like to share this experience. So first of all, okay, we talked about it. We said we need dantrolene. But then even when people were, thinking, okay, we need to stock dantrolene, how do we get the dantrolene? So it is not licensed for use in India. We don't, it is not accessed, it is not manufactured in India. Even if somebody is importing, it is through the gray market. So since there is no license, they cannot import it legally. So my problem was to find a stockist. I reached out to Dr. Bala also at that point of time. So we found out there is one in Trivandrum, through which we finally got, and there was one in Delhi at that point of time. So Delhi person didn't have the stock at that point of time. Finding a donor, which finally, we were lucky that we found a benevolent donor, and we got that money, that 2.5 lakhs, which it took to buy the dantrolene. Also, the stockist will not give you 1 or 2 vials. He wants the whole stock to be procured at one point of time. So you have to pay upfront. You have to pay cash. They will not give you a bill. And so we worked around all that. And actually getting it is simple. Once you have the money and once you find the stockist, it is not very difficult. All you need is a prescription for a patient on an official letterhead. So we got our hospital letterhead. We found a patient. We had not yet operated, but he had some myopathy. So we said, okay, we can get it in his name. He was not affording. So we got the prescription using that patient's name. We got the patient's Aadhaar card. So it was a child. So child's Aadhaar card, father's Aadhaar card, and we did a transfer of payment. We didn't get any bill for that. And then we got the dantrolene. We had to make upfront payment. So till the dantrolene comes, you're still wondering, your 2.5 lakhs is on the line. The questions that remain are, how do I ensure a constant stock? My stock is expiring in September. And that is going to be the question which is going to be there for all of us in the future also. How do we ensure that constant supply? And also, after we got dantrolene, then again our questions started, the dilemma started. Because once we said, we have dantrolene, how do we give it to another hospital? So after we procured it about 2.5 years back, I've got at least 4 or 5 inquiries. We had inquiries from Pune, we had inquiries from Bombay itself. We gave out 3 vials to a patient who actually survived. He had some AKI, which became chronic kidney injury and all that, but he survived. So the problem was that how do we get? So we said we have to get the payment from the patient, and they also had to pay in cash because we can't show any other transaction. And in this situation, usually patients are willing to pay because their patient is really, going to succumb otherwise. So we got cash for that, and we managed. We also had to ensure that we have adequate stock, because if you give out all our vials, if you have an adult, all our 12 vials will go in that. So that was the ethical dilemma we are still debating. And now we are left with only 3 vials after using 6 vials in our patient, which recently. So to summarize, the need of the hour is increasing awareness amongst our own fraternity, amongst surgeons, amongst all the stakeholders, which includes the hospital, because finally it is, if there is a medical legal issue, everybody is going to be involved, isn't it? Make dantrolene available at institutional, regional levels, because there's no point having dantrolene in other city because you have to give it in a timely fashion. Having an MH hotline will be useful, because if you can call out to some colleague who's been there in that situation, maybe that will help you in an emergency. Having a national registry for reporting, that's the only way we can make licensing or import legal. If we make imports legal, I believe maybe the cost will come down. The best thing is to make it in India, and I think ISA is working towards that. The question is, despite knowing about MH and its lethal potential, does its rarity make it ethical for us to administer general anesthesia with no access to dantrolene? And that is the question which we all have to ask ourselves as we are, grappling with this whole situation of the cost of dantrolene. So, to summarize the lessons we have learned, the lessons I have learned is that early recognition is crucial, because stop the offending agent, maybe you can minimize harm. Early intervention can minimize harm. Dantrolene is the only antidote, and it is life-saving. And multidisciplinary coordination is key. Involve the hospital, involve the geneticist, involve the ICU team, because ultimately the patient will have to go to the ICU, and that continuing management will have to go on. So multidisciplinary action is crucial. With that, these are my references. Smith's textbook of pediatric anesthesia gives a lot of very valuable information. Peds anesthesia, this is from the Society of Pediatric Anesthesia, and they've got a lot of checklists, including the MH checklist. It is available for free on the internet. You can download, print it, keep it with you. And this is the Malignant Hyperthermia Association of the United States, which gives a lot of information, including the checklist on how to manage MH. Thank you so much for your patient hearing.
Okay, thank you, Nandini, and thank you, Dr. Mutha. Both your talks were really, really thought-provoking. We've got some 60 questions in the chat box. I think Dr. Anita can look at the chat box, but I have some very pertinent observations, questions. They say that, you take the patient on an ambu bag with oxygen, okay, till you can change the change your machine, or blow oxygen through them. So that is one thing that I would just like to share with everybody, that that is one thing to do. And early dialysis is something that just keep the kidney kind of perfused and thing. And there is also a mention of oral dantrolene. Okay, so I want everybody to just understand this, that there are at least 10 cases which have been managed with oral dantrolene. Now, oral dantrolene is easily available because it is used for spasticity. And what they have said is that in all the reports, they have said that up to 5 milligram per kg dissolved in 50 ml of, of water, you give it through the Ryle's tube. And means like you don't have dantrolene, but this is something that you can try. Of course, early is very, very important. But if we can just keep a stock of, and it comes in 100 milligram and 50 milligram tablets, and, just keep them around till, you have a source of dantrolene. And they say within 3 hours, you can actually, reverse. So if you can manage this patient for about 2 hours, start your oral dantrolene, and, you might be able to, but the dose is about up to 5 milligram per kg. So that is just something that, we can
Yeah, may I say something? So oral dantrolene capsules are available. Actually, I didn't put
And
in
in
my
50 ml.
presentation. Yeah, only because the recommendation is IV dantrolene. That's the reason why I didn't
Of
put
course, but you
Yeah.
see, these are all, we don't have it,
Mm.
but
May
this
I
can be
add
tried.
something, Pratibha?
Okay.
I
So
rem-
I'm not saying that if you have IV, why will you give give
No,
oral?
I remember the first RYR case where we didn't have dantrolene. The orthopedic surgeon came up to me with a bunch of, capsules, and I just kept it nearby thinking that, somehow it will help me. So
Yeah. So
probably.
just, because it's so cheap, it is available. You don't have to, we don't yet have dantrolene access as
Mm.
such, but, just an SOS. And it has been done. And at least I have read 5 cases, which means
Can
have
I
been.
add something?
Pardon?
Can I add my comment, Pratibha?
Sure.
Take care, madam. It is a great news that oral dantrolene can be given. So there was a question in the chat box regarding cases in a small setup. So I think oral dantrolene can be stored by all hospitals because
The
it doesn't all those import difficulties. So I think through rice tube we can give it.
Yes. And see, now everybody's got a little aware. So why not try it? You don't have IV dantrolene, why not try it? And you can just keep a stock in your cupboard or whatever. The other thing that I wanted to actually share was that how regulations were made in America. Okay, uh, the the Society of Ambulatory Anesthesia in the US, what they said is that if you want to stock scoline, okay, this is for MH so that you prevent MH. So if you want to stock scoline, you have to have the dantrolene full set available. So, most of the people, for daycare, endoscopy, they just stopped using scoline. But I'll tell you what the downside, the flip side of that was that there was this lady called Joan Rivers, okay, a celebrity. She went to an endoscopy suite, and over there she had a spasm, simple spasm, but they didn't have scoline available. The person could not be intubated. She went into hypoxic damage, and after I think 6 days or something, she died. So they had to review their scoline directive, and now they have to keep scoline in a locked cupboard. Okay, if they don't want to keep dantrolene, but that's what I'm saying. So, uh, not having dantrolene is not just an India problem. It is not, maintaining dantrolene is a worldwide problem, and it is really, really not easy. The other thing is now Dr. Mutha is saying, or ISA has picked up, it is not a sustainable thing to every 2 years, do crowdfunding and get dantrolene. So what we have to really do is that uh, through the state government, because health is a state issue. So I am proposing, we've already put the fact that dantrolene is not available on the grievance cell of the PMO. Okay. Now they have directed us to the state because the state is supposed to look after your health issues. And now I will tell you where we have to kind of apply. There are centers of excellence. Okay. So KEM Mumbai, I was just finding out for Maharashtra, KEM Mumbai is the center of excellence for Maharashtra, and they have something which is called a rare disease
Registry.
1 second. There is through the Director General of Health Services, we have to apply to the rare disease cell. Okay, they have the center gives 50,000 rupees per person if we can show that rare disease. Okay, so there are some funds available in those in that region. So we will, and then there is, you can take away GST, basic customs duty. So this is all given in the Rare Disease Act. okay, which has come in 2021. So we can do some access or advocacy for stating that dantrolene is a rare disease, because then you can have a supply which is available, because one hospital having, or even I would say Noble Hospital having the drug, by the time it comes to say Semagat or something like that, it may really be of no use. So making it available at a lower cost is what ultimately we have to kind of look at. Because like Nandini said, that, yeah, I have it just now, but who is going to, kind of be the donor next time? That should not happen. And some way we have to do this advocacy and see that, okay, for 2 years, now we have 2 years, so we've got some dantrolene in the city, we have some time. But Anita, that is where we have to go, because it's a state thing. Even if we have put up the whole thing in the PMO registry grievance, they have directed us to the state. And actually there is a secretary who has been assigned, but he never picks up the phone. So I am actually on it, but the centers of excellence have been actually allocated just last month. So we can go to, we don't know who is, just find out from KEM who is on the rare disease registry board. And, we start doing that, because it may not be easy, because they need a patient. They want a patient. So that may not be, so we have to do some circumventing or whatever it is.
Madam, can I add something? You rightly said about legalizing import. That is one way to reduce cost. The second thing, and this I wanted to share, is through the accreditation bodies, but because we had our NABH inspection, they didn't ask. But when JCI came for inspection, they actually asked about, do you have dantrolene? And luckily we had it at that point of time, and they were quite impressed. So it's not that they would not have given us accreditation without dantrolene, but with dantrolene, that was an added sort of thing, which kind of said that we are a safe hospital for anesthetizing any kind of patient. So they actually asked me, have you done the MH drill? And I had not done the drill yet, because we had just procured the dantrolene. So that was their recommendation after the inspection, that the department conduct the MH drill. So we conducted the MH drill. So this is one way for all corporate hospitals. It's like carrot or stick approach, So you get the accrediting bodies to also say that anywhere GA is administered, you must have the antidote.
Yeah.
Here,
The
madam,
other thing
can I
is,
add
I think
something?
all anesthetists need to put up that we need dantrolene. At least
Yes.
that much they have to say.
Here,
Because
can I add?
no, give it to the management that we need dantrolene. Okay. And since Pune now, dantrolene has become such a buzzword, they actually asked, the criminal case was lodged against the anesthetist. And they asked the anesthetist,
Madam, I wanted to ask you one thing.
where did you call for dantrolene? Give us the numbers. And since then, we have approached 6 pharma people. Every day we write a mail that you've not replied. So they are not able to, because in the press they said that such a simple drug was not available. So the criminal case went in such a way that they actually asked the anesthetist, which pharma company did you call to ask for the drug? So I think what we can do is just send a thing that there is a need for dantrolene, okay? And then hopefully we are safe, because there is nobody can expect an anesthetist to carry dantrolene with them.
Yes.
Dr. Pratima, can I add something?
Yeah.
Yes, madam. And then we will have Dr. Bala Venkat sir's comment. He has joined back.
Yeah.
Madam, please go ahead.
Yeah, actually, regarding Dr. Nandini Dave's comment about NABH, I had spoken to Bala after our case in Pune, and Dr. Bala has already talked to NABH authorities that they should make it mandatory to have the JCI and NABH that the hospital has dantrolene. So now let us see when this thing gets in the pipeline.
But at the same time, we have to apply for, because we don't have an Orphan Drug Act. Abroad, they have what is called an Orphan Drug Act, where the person who is creating the orphan drug gets a lot of SOPs. So for them, it is easy to create those drugs because they are emergency drugs. We don't have in India, there is no orphan, but we can go through the rare disease registry and see if we can get this, kind of, for sustainability. It is basically, even for corporate hospitals, if it is all available at a cheaper rate, they will have to buy it. The problem is the shelf life, actually.
Yes, actually, I say, yes, Sai sir.
I totally agree with Kane madam. As Pune city has become a big buzz in the last few months after the multiple incidences, and we are tried on all the grounds, whatever Nandini and Sandeep they had given the contacts. We have tried all the contacts, including South, North, Delhi. But what Madam said, we need to have, because health is a state issue, and we need to approach to the state. And from the our society and whatever help is required political, we have to pressurize them to make it legalized, and then only things will become easy. It is an orphan drug, they call it as an orphan drug, what Madam rightly said. And for that matter, maybe shortly it will be available in Pune, but otherwise also in coming future we have to regularize this, and we need to take a strong steps how we can make it easily. If the proposal given by Dr. Bala, the Natco company, if it works, really it's a things are going to be wonderful. There should not be a problem.
But even
But
for them, if we can get this registered as a rare emergency drug,
yeah,
for
yeah.
them, they will get SOPs.
That Director General has to take this, because I know how much trouble we got it, and now let us see, because Rubial and Noble, we have put the order in Canada. If it is made available within this 10 12 days, they have said, but maximum 15 days. Let's see, it is now 4 5 days over. I'm waiting for the result. Then once it comes, we'll declare it, and then all the hospitals, corporate hospitals, they have agreed to buy it. There's no problem in Pune city. At least 10 hospitals will buy it, and they will keep it their places. And let's see. This is
See,
what.
regarding the availability, as Bala had said that there is a difficulty in getting 250 orders. So what I had thought that if ISA issues an advisory that each hospital which is carrying out procedures under anesthesia should have dantrolene, then it is very easy to get 250 orders all over India.
It's not that difficult, madam. 250, there are corporate hospital, as Bara rightly said, 5,000 rupees a month is a negligible amount. One can spend.
All the medical colleges, if they can store also, it will be more than
No,
250.
it is really not difficult. Even 250 hospitals in
number actually for India.
Not at all a difficult task.
Maharashtra itself can have 250.
Yeah, definitely, 100%.
Another
Because
thing,
looking at the
also set
increasing
up testing centers, sir. So genetic labs are there, but the contractor testing labs, we also need to set up.
Contact testing labs, at least, I mean, people from metro cities can think of this, Pune, Mumbai, Nagpur, can think and try to set up wherein patient can be nearby regions, patient can be transferred and get it done. It's not difficult for the patients coming from Sangli, Satara and get it done in Pune, but we can think of that way also.
About the genetic testing also, I have inquired with recently we had a lecture from the Reliance Genetic Lab, and he told me it is in New Bombay and they are ready to give the result within 4 days, and they are going to charge some 20,000 rupees. So I think that is quite a reasonable thing.
Actually, yeah, if we have a case, one must have the, kind of the sense to take a muscle biopsy. Because in all the, so if we can make a kind of a checklist, and we can share it with everybody, Nandini, will you help us? And we'll just, kind of share it in the all over that, what to, something to do and what to not do or whatever.
Actually, Dr. Nandini, madams, that checklist is very valuable. Just like the last checklist, local toxicity, we can have the MH checklist. We can paste it, and
So everybody can carry it in their phones, it happens so rarely. But somewhere if you have it on your phone, it really would help.
we have some questions. Dr. Poonam is asking that we need to actually give the dose of dantrolene within 10 minutes of diagnosis. So how can we, the procuring, that means the dantrolene has to be available in the hospital.
Yes.
Actually, nowhere it is said 10 minutes like that, but the earliest you have to administer. Like, there have been cases where a few hours later also they have been administered and the patient has survived. So, of course, earlier the better. That's why you should have it nearby. It's no point after 24 hours or, the more late, the more delay you do, the more the patient is going to,
And here also I would like to contribute what our MH team in Pune has done, that we have decided that we will divide the Pune city in 4-5 zones, and we will keep dantrolene stock in each of these zones. And then we thought of approaching police also to create a green corridor like thing, like what we do for transplants. So if we can have that facility, then we can reach the drug very fast to the concerned hospital.
Yeah, right, madam.
So basically, I think that what we should be doing is to create awareness amongst our own anesthesiologists, that if you have this set of symptoms, like if you have an increasing ATCO2, increasing temperature, tachycardia, in a patient in whom you have given the triggering agents like scoline and the inhalation agents, then you suspect that it could be MH, and you start acting fast. So you go to the checklist. So Nandini ma'am, can you tell us what initial action to be taken? Like when you're trying to procure dantrolene, what are the initial supplementary treatments that you can start in this patient?
So I said it in my lecture also. The first thing is to be, first identify it as a possible image. That is the first thing. Unless you think about it, you're not going to act on it.
High index of suspicion. Yes.
Most important.
Stop the triggering agent, because at least the quantum of insult you are giving will be reduced. So stop the triggering agent, hyperventilate with 100% oxygen, intubate the patient, because that's the only way you can hyperventilate effectively and safely. Start cooling measures, send the labs out. If you send the labs out, you will know acidosis, hyperkalemia, put in a urinary catheter, diurize the patient, and treat arrhythmias. If the patient arrests, CPCR of course will be given, and then try and procure dantrolene, and all this you're doing. Tell the surgeon to stop the surgery, close quickly, get your ICU team also, get help, because you alone will not be able to do so much in this thing. Also collect the blood of the patient, because you say, God forbid, the patient succumbs, at least you have something to send the genetic testing for. So at least that might help you in hindsight that, okay, at least the genetic test was positive. Muscle biopsy is more of a planned procedure and not available here anyway. So that I don't think can be recommended as of now, but at least the blood can be collected and stored for genetic testing.
And the muscle biopsy has to be done within 2 hours.
Exactly.
So it is not possible, and the centers are not there, so it is not possible.
No, I think sending blood sample is a more feasible option, which we undertook in our DY Patil case.
Blood sample, no, madam?
It came positive, so medical legally also it is safer to have the positive test.
Dr. Kane,
I have a question. That suppose you have Indula madam, just 1 minute.
I'm so happy to see Panchal madam here, my teacher. Good evening, madam.
Nandini ma'am, I have a question. Suppose you have a masseter spasm and you have recognized and you have stopped the agent, the trigger immediately, and without dantrolene the patient survives. So does that mean that this was not an MH? I mean, in case you haven't reached the diagnosis, you haven't done the...
Still say genetic testing. Why should the patient have a masseter spasm?
Yes.
First of all, I would advocate, I mean, if it is possible, don't use choline. I haven't used choline for the last 20 years. So if possible, avoid choline. But if you're using and you see something which is different, which would mean a masseter spasm, and you're lucky the patient survives, send him for genetic testing. How much does it cost? 20,000.
Yes, yes. Yes, Indula madam, please.
Yeah, Dr. Kane, I
Yes.
just wanted to ask you, you mentioned about dantrolene capsules. Now, has anybody used it, or is there any experience, or is there any
So
report?
they are case reports, but they have been used and they are available in 25, 50 and 100 milligram. They are being used for pediatric muscle spasm. And very, very regularly they are being used. So it's not something, it's quite freely available.
So then I think the
50 ml and the dose is about 3 times. So about 4 milligram to 5 milligram per kg is the dose when the IV is 2.5 milligram per kg.
No, but 5 cases you mentioned, are they the cases of MH where they had used oral dantrolene?
Yeah, that's what I wanted to know.
Yes.
Anyhow, we can try if there are any cases and if the injection is
These
not
are
available.
case reports. There's nobody who's going to. I'm just saying if you are stuck, this is one of the ways. I'm not saying if dantrolene is available with you, why will you look at capsules? I'm just saying that this is a way in which 6 cases have been managed. Now, whether they were all, nobody has tested but the Lara score is given in all these things.
Pratibha, were they the cases under anesthesia? That's what I'm asking.
Yes.
Yeah. So that means they are most likely to
Lara
be
score
MH
is only when ETCO2, everybody, anesthetists have reported.
Yes. So that means they have been used in MH.
And the 3 cases which I have read were under anesthesia only, where they had given rice tube dantrolene.
Yeah.
Yeah.
That is a very good, actually, it's a very...
And to answer to Anita's question also, if there is a masseter spasm and lasting for more than a minute, you have stopped everything, you have postponed the case, the patient doesn't have any problem, you have to go for genetic testing for that patient and for the family.
Counseling, basically
Counseling and genetic testing has to be done for the family.
And very, very often they are usually, the parents do not want to go ahead. That's very sad, but it happens that they may not want to do the further test.
We have to
About
remember
this oral dantrolene, I want clarity on oral dantrolene. I mean, is it are we advocating oral dantrolene for?
Yeah, I don't think we should, Anita, because none of the checklist, none of this thing, I have not read about it. And the thing is, if we give our people one escape route, no, everybody will take that, including me. You tell me a capsule freely available, cheap, I will also take that, isn't it? I don't think any of the checklist, none of the literature. So I am not sure about that at all.
No, I completely second what Dr. Nandini is telling. This should never be discussed even. I don't think oral dantrolene is an answer for malignant hyperthermia. It's definitely not in the literature, not in any of the textbooks. And I don't think that's a solution. So it's only intravenous dantrolene. I think we shouldn't discuss even about this.
Yes, thank you, sir. Thank you. And I want you to discuss about the effort that ISA is taking for making dantrolene available, sir.
Anita, see, the problem is everyone speaks very good. When they say, like even when Saleh sir said 250 centers, everybody will buy. It looks so simple for a country like India. But you just send a survey and ask them to place the order. Then you will know how many people really place the order. It is an assumption that they will do it, but it's not true. So this is what literally we are going through a phase where when you need to take decisions, all the speech does not get converted into action. That's the problem. So now that's why I think the simplest of the solution, see, NATCO, even if today they agree to start manufacturing, then the MOU is, if we sign with them, it will be a year and a half before it comes into the commercial market. But to do that, they wanted ISA to sign an MOU of 250 vials, which will be 1 lakh per vial and close to 2.5 crores per year. For 5 years, they want us to sign an MOU, which I don't know whether this is going to be feasible. Number two, we approached Neon to market it in India. And they have to buy from the, there are only two major manufacturers of this in the world. One is the UK based, one is the Europe based and the other is the US based. And they've done all the exploration, but what they say is, if we place an order, if we place an order and then they wanted to procure and give it to us. But however, I personally feel the one message which I had sent very recently to all the groups who are under in my broadcast group, we are buying dantrolene regularly from this buyer who is based in Trivandrum. And all the 5 years we have purchased it from him. The requirements are, you need to buy it in the name of a patient. And you need to submit, and they will take 10 days to give you the drug. But you have to make the full payment to them. So he suggested that if a large number of people can place an order, he says that so many people have called me, but not a single order has reached me so far. He says at least 50 phone calls had come in the last 2 months because I hear there is some problem that's happening in the country, but not a single purchase order has come. How do you answer him? So the simplest solution, which I think now, number one, is either consider every patient as a potential malignant hypothermia and avoid all the triggers and go for complete total intravenous anesthesia if the facilities are available. That's number one, which is not feasible. So number two is to have the drug available in all the cities. Actually, ideally, all the hospitals, but if not, as Madam mentioned, the major hospitals, city getting divided into 4 or 5 zones. And that's the next option. And this 120 milligram for 1,20,000 rupees with a shelf life of 2 years, for me, at this point of time, seems to be the best way to procure the drug. And he's very reliable because we have been buying from him all these years. So we need to think about this possibility. And Anita, I can share that his number and name to you, and you can put it across in the group. And the commercially available formula, every currently available company, everything he has given in black and white. At this point of time, the immediate solution seems to be procuring this particular molecule of 120 milligram vials. And also regarding, we have done a lot of work on genetic study. Yes, it's possible, but the muscle contraction study definitely to establish such. We are in touch with one of the pioneers of this is Kumar Bilani from United States, and he has offered to come and set up one center. And it's like the problem is how many, again, it comes to the question of how many people will send. Everyone say we'll do it, but how many people will send? What should be the total amount of money that would be spent in establishing the laboratory, the utility of the laboratory? Everything is under question mark. So this is in a nutshell that there are a lot of questions, there are a lot of answers, but at this point of time, the simplest answer is all major institutions should buy this 2-year shelf life, 120 milligram vial, rather than going for the 20 milligram vial. And in fact, 20 milligram vials production has been stopped recently in Europe. So best is to buy the 120 milligram, one vial in all major hospitals who are willing to lend it to all the private smaller hospitals when there is an emergency. At this point of time, I think that's the simplest answer. And I would completely believe only on intravenous dantrolene and not probably discuss anything about oral dantrolene. And also, more importantly, this webinars create a lot of awareness about trace of end tidal and tachycardia, always shut off your triggering agent. I think that if that message goes across, because I've spoken to several anesthetists who have handled this, all of them said they thought it was a light plane of anesthesia and increased the depth of anesthesia by giving more trigger. So these are some of my views. Thank you, Anita.
Thank you, sir. As sir has said that though we are trying, ISA National is trying hard, but it's not a straightforward journey. It's not that we will ask and they will procure. Another challenging thing is if one hospital is stocking dantrolene and some other hospital asks for it in emergency, who will pay for the dantrolene? Because once it is taken and who will pay? The patient will pay, or the anesthetist will pay, or the hospital. So all these are unanswered questions. And
Anita, for that we are trying to create SOPs.
okay.
At least in the city of Pune, that we have formulated. Now it has to be accepted that the patient has to pay. The anesthesiologist who's facing the case will also shoulder the responsibility, and the hospital also will shoulder the responsibility. There was a debate about how much time limit should be given, and 1 month we are planning to give. So it is still not, once the drug becomes available and once we finalize the SOPs, we will share it with the state branch. We'll share it with you.
Because the stockist that we are talking at Nasik level, stockist is ready to stock, but the question is if somebody procures dantrolene in an emergency and then is not ready to pay back, then what do we do? So
No, here what we are going to do, we are going to buy the drug, we are going to keep it with us, and then that has to be repaid. So it is not with the stockist.
Anita, all the cases which we have used, all the 3 cases which we have used, patient only paid. Patient only paid. It was made very clear that, and also we made all of them to do the genetic testing. And in fact, one of the family, they based in Dubai, they came for Dubai for surgery. In Dubai, there is a center. There are 2 laboratories which do this. The muscle contraction study. So we sent the entire family there to that center. So,
but Bala sir, there is one hitch in this. If the patient is affording, no problem. But and if there is a unfavorable outcome, if the patient dies, there are concerns in the private practitioners who are practicing in smaller nursing homes, whether the patient will be ready to pay.
Madam,
so
I
that's
think,
why we have come
Madam,
out
personally, personally, I think this debate should happen later. But first debate is to make it available. I think we are trying to speak, speak on
we
something
have
when we
taken
have
all
not.
the steps. It is now few days matter when the drug will become available in the city of
True, madam. True.
We'll have a second debate for that.
one more question Dr. Pankaj Gupta has asked: do we need to modify our consent forms?
Actually, we have to modify our PAC form. Pre-anesthesia checkup form, we have to modify and take all the questions with respect to malignant hyperthermia in those forms. And then we can, and see, we have added malignant hyperthermia in our consent long ago.
Yeah, but I think Sandeep, there we have to mention that because the case which took place in Pune, there was no history, there was no family history, previous exposure was uneventful. So we have to
and the
mention
consent
there
also
that
had malignant hyperpyrexia written in it.
Yeah.
That consent had malignant hyperpyrexia, but the consent doesn't save you when, I mean, maybe because the patient has not understood. So that is what they say, that you may have a 10-page consent mentioning everything. But, when
always the first time, when the patient is exposed to the trigger and was not exposed to trigger beforehand. So there is no history.
No, that's also true.
No, the consent can have many things, but when things go wrong in a young patient, that consent may not save you from the immediate problem. May save you later in a consumer case, but that criminal case and everything is rather means it doesn't save you. They always say it because allegations can come anywhere.
Yeah.
So the allegation of negligence, you just have to defend.
Bala sir wanted to say something.
Hello.
Yes, sir.
No, I think the joy of saving a life, I think, is the most crucial one. And whether they are poor, rich, for example, in all our trauma victims, when they come in class 3, class 4 bleeding, we don't ask money and we save all of them. And not that probably in a year, maybe one may not pay, but all the others pay. They're so grateful to us for having saved their life. So I think we as the doctors in charge of a surgical patient, I think our utmost thought should be to save a life, and money will flow in. I don't think money is an issue at all. Had that been an issue, Ganga Hospital will not be what it is today.
Yes, I fully agree with you, Bala sir.
Even I fully agree, Bala.
Yes.
I was so happy when we could collect the funds, when we, appealed people, all the members paid, and we have been able to collect funds to buy.
No, it's very good, madam. It's excellent. It's excellent. And I think now these webinars, number one, very crucial and important to spread the message that this can happen in this country and patients can be saved. If this webinar can send a strong message, and I think we have done the job in the first phase, because everybody said that all those who encountered this problem said they never expected that it to be malignant hyperthermia.
There is one question that in absence of dantrolene, can we try soda bicarb, mannitol, and calcium channel blocker? Steroid.
Nothing. No answer.
Calcium channel blockers, not
Should
at
not
all.
be used. No,
Not at all. In fact, they are contraindicated.
Yes, that Nandini ma'am covered in her lecture. Yes.
Malignant hyperthermia,
Soda
malignant
bicarb, yes.
hyperthermia, intravenous dantrolene. That's it. Only one answer.
The soda bicarb is an adjuvant treatment. It's not
Yes.
a treatment for malignant hyperthermia.
So we have covered all the questions in the chat. Most of them.
Excellent. I think it's very nice. Thank you so much for doing this, because we need to spread the message. And at least next time when NADCO does a survey, people will say, yes, there is malignant hyperthermia in India, because otherwise they got such a negative feedback. Now, with this kind of awareness, I think many people will say, yes, I know this has happened in this country. Thank you to
Bala, you need to give them a list of names who will say yes.
Bala, Dr. Bala.
Yeah. How did they get all the wrong names?
Dr. Bala, can
yes, Dr. Nandini. Yeah.
can ISA take up the job of setting up a national registry? Is that possible and doable?
That's also possible, madam. Actually, yes. That's the next thing. The first thing we did was production, trying for that. Next thing we did was we did a podcast. So a podcast which we tried to the IJA podcast to create awareness.
Right.
And the third thing that we have brought it in the GC is to get the registry done, a registry. So then we will have a clear idea. But now again, the concern is how many people will really admit, how many people will use it. But it's on the cards, madam. It's on
You
the
have
cards.
to make
Thank
it
you.
I think a
anonymous
person
for
who had
medical legal reasons. You just have to make it anonymous, because that is
Yeah.
how, don't ask for too many details. Just ask for the patient details.
Yeah, just the critical
Not who
incident
has done
reporting.
it, which
Yeah.
city, no. Was
Yeah.
dantrolene available, not available, how it was managed, and what was the outcome. That's all we should collect for some time.
Yeah.
Actually, sir, Murli Thonde Bhave had made a critical incidents reporting website
Yeah.
earlier, which was launched in Ganga during
No,
Kartik.
Zelsia, that was an app.
Hmm.
Zelsia, we are actually working with the same group, and we want to relaunch that app as well, both for data collection and critical incident reporting, both together.
So in that anonymous reporting, there should be no city, no thing, because medico-legally, somehow then that becomes a little bit of a problem. But if we just get patient's age and,
But why
patient
should it be
details.
a problem? Because anyway, when the case is in the criminal court, we are going to defend as an MH case, isn't it? So why should there be a problem?
No, registry is a totally different thing, madam. Registry is only to collect data.
But we can submit it later on. We can give some timeline to submit, timeline.
No, but you don't need for data. We don't really need the patient's name or we don't need it.
No,
But
madam,
why should it go
problems-
again?
Madam, the problems like suppose the opposite lawyer, he will ask you questions like why was
Dantrolene not available.
why was Dantrolene not available? Why did you give scoline? Did you have any other options? And so all these questions could be problematic, if for that person.
The registry has to be quite anonymous, and it works. It works. Because many adverse event registries are quite anonymous. But you get data because people then freely give the details.
Sale sir, are you there? Dr. Sale in Pune, he is procuring and will shortly come to know whether he gets Dantrolene. He is saying in 12 days time, Dantrolene he will make available in Pune city. So thank you very much. I want to thank Dr. Bala Venkat sir and Dr. Pratibha Kane madam for their expert guidance, and seniors like Dr. Kalpana Kelkar madam, Dr. Indula Panchal madam. Thank you very much for joining in and giving your inputs.
Thank you.
I'm very hopeful that something good will come out from this webinar, and I really wanted an approach like we want to first increase awareness amongst our own people who think that MH never happens in India. So, and while cases are happening and we don't know what are the signs, symptoms, and we are not diagnosing them properly, and that is why we are saying that okay, MH is not there. So it is happening very much, and we are trying to diagnose, trying to increase the availability of Dantrolene. So let us close on this hopeful note that we all together, ISA, along with our members, our city branches, our ISA national officials, all our faculties which are will help us, and we will move forward in a direction and towards making this anesthesia safer for our patients. Thank you very much, Dr. Nandini, Dr. Sandeep Mutha, for excellent lectures.
Very nice, Dr. Mutha and Dr. Nandini. Thank you very, very much.
Yeah,
it was a very thought-provoking session.
very well done, Nandini.
Thank you, madam. Thank you so much.
And thanks, Anita, also.
Thank you, everybody.
Thank you, madam. Thank you. And good night.
Okay.
Good evening.
Good night, all. Your Excellency.
And Panchal madam, it was so nice to see you after so many days. I think she has disconnected.
Anuj, how do you